So the topic assigned to me is management of soft tissue injuries in maxillofacial region. And this talk is aimed at relatively younger colleagues who are just joining plastic surgery or trauma surgeons or general surgeons who are handling these patients or as the primary and secondary survey. So this is very important because best of the results of oral internal fixation are marred in case we don't manage the soft tissues adequately. And this is the theme of this presentation. And apologies, this will be a fairly basic presentation, but I think our audience demands that. So no conflicts of interest. So going by the etiology, so commonly you see soft tissue injuries or facial-maxillary injuries. Majority of the cases are in road traffic accidents, homicidal injuries or bites, and rarely these days we also see cases of gunshot injuries. So road traffic accidents account for 70% of the cases of facial-maxillary injuries, and among these, 25 to 30% are associated with soft tissue laceration or loss, and these typically follow the T-shaped distribution. So meaning thereby only the prominent regions are involved, like forehead in 22.6% of the cases. Primarily forehead and periorbital regions are involved in majority of these cases, and the lateral injuries are relatively rare. So this is a typical road traffic accident patient which trauma surgeons or plastic surgeons will usually see. And it appears a bit grotesque initially, but with stepwise management, I think all of us should be able to handle these appropriately. So sticking to the basics, so all these wounds are primarily contaminated wounds. So we have to convert it into clean wound and remove all the debris, and simple washing will not do because road traffic accident, a lot of muck and sand and other particles are inside the wounds. So we have to do a proper surgical scrub and preferably with a brush, meaning thereby some sort of anesthesia has to be given, and all these patients have to be managed in primarily in a local OT or a general OT scenario where adequate lighting is there. And we should attempt to close these wounds within 24 hours. So how to clean these wounds? There are various methods, like pulse lavage system is available. So all these systems are available at apex centers and may not be available at all the places. So these produce a pressure of around 10 to 15 pounds per square inch. So in case we are not having these systems, we can simply use a 50cc syringe with an 18 gauge needle to irrigate. So this will produce almost similar pressure and achieve a good cleaning of the wound. So once the contaminated wound is cleaned, then we can go ahead and suture it. A special care, like we usually ignore the abrasions, but whensoever in road traffic accident these abrasions are there, there is invariably a traumatic tattoo. And in case you don't remove it with a pulse lavage system or a high pressure system, then chances are this will go in the subcutaneous tissue, and later on it is very difficult to remove these small particles. So primary management is of utmost importance. And another thing is that in head and neck, the vascularity is very good. So we should only do judicious sharp debridement of the margins as opposed to the lower limbs, where extensive debridement has to be done, all degloved skin has to be excised. In this, only excise the clearly devitalized tissue, because you see such a deep vasculature is present, deep and rich vasculature is present. And even large skin flaps which are elevated on small vessels can be easily salvaged. And after the debridement, excellent approximation of deep dermal layer has to be done, usually with a monocryl or a vicryl. Usually we'll use 5-0, and thereafter we can use either interrupted or subcutaneous suture, and preferably it should be a monofilament suture, preferably a 6-0 suture. And coming to the eyelid injuries, all eyelid injuries merit examination and under anesthesia. This may be a local anesthesia in form of 4% xylocaine, and because we need to see what is the extent of damage, because all these upper and lower lamella of the eyelid are loose hanging structures and they appear grotesque, but usually the tissues are already present there. So we have to rule out the LPS injury, and in case ptosis is present. In case you don't rule it and simply suture it, what will happen is after 24 to 48 hours, granulations form and it is difficult to identify the muscle. So you won't be able to close that muscle. So they have to be, in case there is a ptosis or decreased movement of the upper lid, we should suspect LPS injury and explore for it. And in case there is rounding of canthi, in case we see something like that, chances are the canthus is either damaged or dislodged. So we should take care of that. In addition, in case the patient is having epiphora, the tear film forms and there is leaking of the eye, then we have to rule out the canalicular injuries also. So to handle all these things, examination under local anesthesia in case of adults and general anesthesia in case of pediatric age group is very essential. So as we all know, the lid consists of 3 layers. The outer lamella consists of skin and the muscle, middle lamella of the septum, and palpebroconjunctival layer, the inner lamella. And these have to be repaired separately and individually. In addition, we have to rule out the canalicular injury. So a special reference is made for the gray line, that is between the palpebral conjunctival layer and the middle layer. In case there is in case we don't match it appropriately, there are chances of anomaly which will be seen from a distance. So how to handle it? Put a key suture and try to elevate and invert the lid. And then use buried sutures in conjunctiva. This is very important. In case you let the sutures go through and through the conjunctiva, the suture will abrade the cornea and can produce infiltrate and in some rare cases, even perforation of the eye also. So you should avoid doing that and put only the buried absorbable sutures, and middle lamella can be repaired with absorbable sutures. And thereafter, we can use subcuticular or interrupted sutures, which can be a non-absorbable sutures, which we can remove after 5 days. So how to, like a case which appears as bad as this, in case we try to stick to the principles, clear the contamination and try everything was there and only thing it was dislodged, and we can bring the normal anatomy and have a good result. Another case in which there is degloving of the both upper and lower eyelids. It appears grotesque, but once you follow this principle, then good closure can be achieved. So a special reference for the canalicular injuries. In case you see there is leaking of the tears, so we must suspect all the lacerations which are medial to the caruncle of the lower lid, then we must suspect there is canalicular injury, and we can compress the lacrimal sac, and we can come to know the where is the other end of the opening, and we can cannulate it. Different catheters are available, and sometimes you can use 20 gauge cannula and use it to line the canalicular and achieve a closure over that, usually using a 7/0 suture. So then we can come to the forehead and the brow injuries. So in all these injuries, we have to rule out frontal sinus fractures. We have to get a CT scan whether there is outer or inner fracture. So that is not the part of this presentation. So in case there is no fracture, we can proceed with the closure. Primary repair for lacerations and small losses can be easily done. Here the key is to preserve the medial brow, because any anomaly of the medial brow will be much more visible than the lateral brow, and we can easily mobilize the lateral brow. Like this, the medial brow has been brought to the normal position, and this is still to be brought down, upper part, and we can advance it, and we can achieve a good closure, and while focusing on the medial brow, because height of the brow has to be equal. The pinna injuries are a bit different the way we handle it, because the cartilage receives the supply as a diffusion. So in case there is degloving, both on the medial and the lateral side, and there is loss of perichondrium, and the time duration is more than 4 hours. So chances are this is a contaminated cartilage, and this has to be removed. And after removing, we can simply do a single layer closure of on both the sides. And we have to be aware of hematoma. So in case there is hematoma, it will elevate the skin from the cartilage and will lose the cartilage. And so it is very essential to evacuate the hematoma, achieve good hemostasis, and thereafter do a contour bandage. I would like to highlight that we have to excise all the exposed and devitalized cartilage, because in case we don't do that and still achieve a primary closure, chances of suppurative chondritis are there, and thereafter it will lead to the loss of more cartilage. And as plastic surgeons, we are well aware how to handle the tissue losses. So which is not the part of this presentation. We can go ahead and do secondary reconstruction, one example, and another example in which we can achieve reasonable results. So nasal injuries fare a bit different from auricular injuries. The reason for that is the nasal cartilage is firmly adherent to the underlying mucosa. So even if it is exposed, it is getting some blood supply. So here, as opposed to pinna, we have to salvage whatever the cartilage we can salvage and do a meticulous repair of the underlying cartilage, repair the nasal mucosa, and whenever we do a nasal mucosa repair, put a splint because otherwise stenosis might happen. Evacuate the septal hematoma, and usually patients are not cooperative in trauma scenario for layered closure. So a general anesthesia is preferred for these cases. Another important point is whensoever, like in initial phase of residency, there is a defect. So sometimes the residents try to do a forehead flap right away, which is not, we are not doing justice in that scenario. So because already the areas are traumatized, try to achieve whatever closure you can achieve, skin to mucosa closure. And we can always go back again after 3 to 6 months when vascularity is not questionable, and we can do the flaps whatever we need. So this is the case of tip reconstruction, which was done secondarily. Lip injuries are fairly straightforward. All of us are aware. We have done a lot of cleft lip and palate repairs. So the importance here is to tattoo prior to infiltration, not after that, and achieve a layered closure. Oral mucosa first, and then try to achieve red line match. That is the wet and the dry mucosa match, followed by orbicularis repair, and thereafter white roll match, which is fairly straightforward for plastic surgeons. So I think Dr. Manish also, I think, was talking about facial nerve injuries. So whenever we come across a patient who has a ipsilateral motor deficit in presence of a cheek laceration, we must suspect facial nerve injury. And we must distinguish whether it is a palsy or complete paralysis. Palsy may be because of some partial injury or compression, and paralysis usually the nerve is cut or damaged or contused. So all the injuries which are medial to the lateral canthus, there are extensive cross innervation, like you can see. So we might get away in case it is not involving the main branch areas. We need not go ahead and repair it. But all the injuries which are lateral to the lateral canthus, because here the major segment of the facial nerve divisions are there. So we must repair them under microscope. And this repair, we cannot delay it. We have to do it within ideally 48 hours. The reason for that is manifold. One is that after 72 hours, Valerian degeneration will occur. And the stimulus which you go to the distal segment may not be easily visible. And second reason for that is there is a lot of granulation formation. So it is difficult to identify these nerves. So people who have done it will be aware that how flimsy these small segments are. So we have to do it under microscope and nerve stimulator. Like this case, which was operated at some other hospital, and the patient came with facial palsy. So when we opened it, we found the main truck injury, and divisions were also injured. So they were repaired under microscope, and we have to do a direct neurorephy, usually epineural sutures. Since it is a pure motor nerve, nothing else is needed. No orientation is needed. And then sticking to the same area, how to handle the parotid injuries. When we see there is a gland injury, so we can directly suture the enveloping fascia with a pressure dressing, which can be maintained over 48 hours. And in case there is formation of a silosyl, or there is some secretions which are coming out through the skin, we can start glycopyrrolate and transdermal scopolamine. We can also use botulinum toxin. What happens is the gland usually atrophies after pressure, and in case there is no injury to the parotid duct, so these will the leak will stop. But in case there is a duct injury, so then we have to do the cannulation of the duct. So we can confirm the duct injury by cannulating it from the intraoral side. And then similarly, we can put some pressure over the parotid gland and we'll come to know where is the other end of the parotid duct. And this can be repaired over a stent. The stents are usually expensive, but we can use a epidural catheter, 16 gauge epidural catheter, and bring it out through that. And later, once after 2 weeks, we can take it out. Sometimes we come across patients with facial degloving. Patients usually will have severe bony injuries, and usually they will have comminution which is also present. And once you open these wounds, they'll come from a primary center like this. Once you open these wounds, you'll see large skin flaps are there, which are surviving on precarious vascular supply. So it is a red flag. What should we be doing? So all the bony alignment has to be done through limited incisions, taking care that you don't devitalize these segments, because correcting this would be a bigger challenge. And we can sometimes do IMF. And in case the exposure is going to hamper the blood supply, so we should focus on occlusion and preserving the blood supply of these large tissues. So we should not undermine it excessively, because then the blood supply will be lost. Thereafter, closure is, as we all know, closure of the oral mucosa, muscle layer and skin, which is straightforward. Another case of facial degloving in which hemi-nose has got degloved, and you can see the cartilages here. So with the layered closure and using a nasal stent also for around 6 weeks, a reasonable closure without the nasal stenosis can be achieved. And what to do in cases of extensive tissue losses? There will be some cases in road traffic accident when the patient was pulled along with the vehicle. So chances are there will be a loss of tissue, but still the loss is lesser than what it appears. So you should take the patient in OT, decontaminate the wound, and try to bring all the tissues in normal alignment. And what you will find is you can handle majority of the areas from the primary tissue only. There will be limited areas in which there is actually tissue loss. They can be managed by skin grafting initially and followed by secondary reconstruction. Doing flaps primarily will be counterproductive in a trauma scenario. In the second major chunk of this facial maxillary injuries is by the animal bites, and usually these are dog bites in our part of the world, and hilly region it could be some bear bites also. Or this is a category 3 wounds. So we have to do a meticulous wound management, especially in regard to rabies. We have to do a thorough wash at least for 10 minutes. In all these cases, we have to give rabies immunoglobulin. Usually human HRIG is easily available. We have to give the solution in 20 IU per kg body weight. And majority of it has to be given around the wound edges. And rest, which we cannot give around the wound edges, can be injected in the intramuscular area. And also for active immunization, anti-rabies vaccine has to be given. So once you have given this immunoglobulin, we can do the suturing after 3 hours of HRIG, because by that time the human anti-rabies immunoglobulin has percolated in the surrounding area, and any handling of tissue, the virus has been devitalized. We are thinking that all these wounds in which we cannot identify the animal, they are potentially can cause rabies. So we have to treat them accordingly. So tissue deficits, again the same principle. Try to achieve skin to mucosa closure or primary closure, whatever you can. Use grafts wherever you want. And secondarily, we can reconstruct it with flaps. Another thing, as a plastic surgeon or trauma surgeon, we should be aware is gunshot or projectile injuries, in which the initial appearance is very grotesque. There is extensive soft tissue damage along with bony comminution. And the initial or novices should understand the injury is much beyond the entry and the exit wound. As we know, these projectiles or bullets will cause a pulse cavitational effect. So it is all these injuries are a combination of direct and indirect damage. Direct damage by the wound and indirect damage by the cavitation effect, as well as the direct burning effect when the bullet passes. So how should we handle it? We have to decrease the contamination as well as the non-viable tissue. We have to excise that. So So this has to be managed in something similar to the way we handle lower limb trauma. We have to do a early primary debridement, and then in addition, we have to excise the tract. Whole of the tract has to be excised. And special care in such or blast or these bullet injuries, we have to look after any if there is any traumatic tattoo. So we have to use brushes to clean up all these traumatic tattoos, because otherwise they will get impregnated in the subcutaneous tissue. And after the initial debridement, we have to repeat the procedure at 48 hours. And thereafter we have to do layered closure. And again, secondary, like in this case, there was loss of the mandible, which was made good by using free fibula and overnight skin island. It requires some corrections here, and usually it is done secondarily. Like this patient has been operated initially, thereafter we have to do secondary reconstruction for the bony part. So to summarize, the face is very important for complex social interactions, and results of adequate or a very good bony fixations could be marred by casual soft tissue repair. So we have to focus on careful and meticulous repair. So this is the best way for restoration of function as well as cosmesis. Thank you.